Hello, I am Eugenio M. Rothe, MD, Professor of Psychiatry and Public Health at the Herbert Wertheim College of Medicine at Florida International University in Miami, and I am also President-elect of the American Academy of Psychodynamic Psychiatry and Psychoanalysis. And today I am going to be talking about post-traumatic stress disorder in the time of COVID. Some of the characteristics of the COVID trauma include that the enemy or threat is invisible. It could come from anywhere, it's sudden and unexpected. Initially, there were a lot of unknowns, rumors and misinformation. The disease killed some people, not others. So you wonder, what about me? How long is this going to last? Will the cure or the vaccine be worse than the disease itself? And other results are the physical isolation and the loss of contact that has been produced as a consequence of the pandemic, separation from loved ones, especially grandparents who needed to be protected from the virus, the loss of routines, children not being able to attend school and causing an undue burden on the stay-home parent. It's been a disorienting experience in time and space with loss of income, some people suffering financial catastrophes, and of course, the loneliness that results from the experience. We also lose the illusion of safety. The illusion of safety is a concept that we all have a fantasy that nothing's going to happen to our physical selves, and we need that to survive. Like, for example, when you get on the highway, you have to think that the 18-wheeler that's driving right next to you is not going to hit you, because otherwise you can't function. But when we start losing people very close to us, then the idea of death and harm becomes very real, and one loses the illusion of safety, and as a consequence, it generates a lot of anxiety and fear. The other thing that has been lost is the ability to have official funeral rituals. There are rituals that are universal in every culture in the planet, and there are three fundamental things that happen in every funeral ritual, which is the presence of the body. So having the body present makes it real that the person is no longer alive. Eulogies remember the departed, and by listening about stories of the departed, we internalize the memory of the departed, and the departed continues to live inside of ourselves. And finally, the family and the community gather to support the bereaved. And we have lost this ability, and we've had Zoom rituals of funeral rituals and so on, which are not the same as being there in person. So going back again to post-traumatic stress disorder, we begin with the history of PTSD in the American Civil War. The novelist Stephen Crane wrote an important book called The Red Badge of Courage. In this story, the protagonist cowers out. He runs away from the battle and ends up in a different regiment. The people in the other regiment think he's a survivor and think he's a hero, but deep down he's deeply ashamed because he's actually a deserter. So within his shame, he gets a second chance. And in the next battle, he becomes the flag bearer and is the first one of the second regiment to run into battle and redeems himself. Sorry, and what this points at is that it's a normal human reaction to try to run away from danger at times when maybe we are expected to face danger. And this was based on the Battle of Chancellorsville in the Civil War, where Stephen Crane himself had participated. And here's a rendition of the battle between the Union and the Confederacy. And Audie Murphy played the main role in a movie that was based on the novel The Red Badge of Courage. Ironically, Audie Murphy was actually a World War I veteran. He was the most decorated American veteran of World War I, and a good-looking guy, so he became a movie actor, but he had severe untreated post-traumatic stress disorder. So he died of chronic alcoholism tragically at a very young age, probably self-medicating his undiagnosed PTSD. Then in World War I, PTSD was known as shell shock, and they thought it had to do with the impacts, the sound waves of the bombs that the soldiers had to endure in the trench warfare. Moving on to World War II, the PTSD began to be called gross stress reaction. And for the first time, psychiatrists were incorporated into the military. And so you all remember probably the scene in the movie Patton, where Patton slaps a soldier that has PTSD in the field hospital, which then cost him quite a bit of grief to his career. The PTSD diagnosis really began to be consolidated during the Vietnam War after 1968 and the Tet Offensive, and slowly it made it into the DSM-3. And it appears in psychiatry officially for the first time in 1980. So as soon as the diagnosis of PTSD appeared, immediately childhood trauma with PTSD was exponentially diagnosed. So at this point, there was a lot of childhood trauma, but it went largely undiagnosed. The expansion of the diagnosis was contributed to by Hans Selye, a professor at McGill University, who talked about the neurophysiology of stress. And he hypothesized that stress was mediated by the hypothalamic pituitary adrenal axis, and that with chronic stress, there came a point of exhaustion. And he described for the first time the neurophysiology of the stress disorders. So then we go to the diagnostic classification of PTSD. And so largely we have the type 1 or single event trauma, and type 2, which is ongoing and of long duration. And of course, a single event trauma will have better prognosis than ongoing long duration trauma. So where does COVID fit in? Well, COVID is a type 2 trauma. It's sustained, long-term, constant fear of an invisible enemy. People get sick and even die. Everybody's unsure about how long it's going to last, separation from routines, etc. And so one would consider that type 2 trauma, in this case, COVID trauma, is something to be taken quite seriously. So this is a picture of the Vietnam War, just to remember how horrifying these scenes were and the results that came after. So in consolidating the DSM-3 diagnosis, the PTSD concept was divided into 5 sets of diagnostic criteria. The first criteria is that you have to have exposure to an actual threatened death, serious injury, sexual violence, or be exposed in a different way. You can hear about it, you can witness the event, or repeated exposure. So what that means is somebody watching the television over and over can develop PTSD from continued exposure to the traumatic events, not having to be present in the scene. The Second set of criteria is the intrusion symptoms, the distressing dreams, the flashbacks, the intense reaction over cues that remind the person of the event, with marked physiological reactions like startle reactions, attacks of anxiety and depression, etc. The third group is the avoidance of the stimuli that are associated with the traumatic events. And the fourth criteria has to do with negative alterations of cognition and mood associated with the event, such as amnesias, the inability to remember parts of the event, the paranoia, nobody can be trusted, distorted cognitions, the survivor guilt, it was my fault that I survived. And this sometimes leaves the individuals in a persistent negative emotional state, and they are unable to experience positive emotions. So they're left in a state of irritability and depression. And the last set of criteria is the marked alterations of arousal and reactivity. So these people may end up with irritable bursts of anger, reckless and self-destructive behavior, hypervigilance, and exaggerated startle response. So does everybody that's exposed to trauma develop PTSD? Not exactly. You have adjustment disorder, which is a set of similar criteria that are much milder, and they develop after being exposed to an identifiable stress, and it occurs about 3 months into the onset of the stressor. Sorry. In adjustment disorder, it could present with depression, anxiety, disturbance of conduct, or a mixture of all of the above. So let's talk a little bit about the neurophysiology of the psychological trauma. First, you need a traumatic event. Then you get a prolonged alarm reaction, which eventually alters the neural systems, causing the permanent symptoms of PTSD. And so if we look at a, I guess, diagram of how the brain functions, you have the cortex or frontal lobe, where you have the cognitive interpretation, then the limbic system where you have the emotional memory of the event, and you have the midbrain and cerebellum, which is you know, how to not forget to ride a bike, all those automatic things that we learn, and then the brain stem, which influences the entire brain and creates a state memory. So a state memory means that somebody who's been over aroused for a long period of time, the brain stem is going to send a signal of a constant state of vigilance and alter the entire brain system. Some of the neurochemical changes that occur after the trauma. So we remember that epinephrine and norepinephrine is secreted by the locus coeruleus and then distributed by all the nervous system. And this is responsible for the fight-flight reaction. So if you overstimulate the locus coeruleus for a prolonged period of time, then what you have is a needle that gets stuck on high in the thermostat, and there's a failure to habituate, causing persistent hyperarousal tone. And this accounts for the irritable behavior and angry outbursts, reckless self-destructive behavior, exaggerated startle response, problems with concentration, and of course, sleep disturbances. This is a picture from the movie Rambo, and Sylvester Stallone interprets a very DSM-like diagnosis of PTSD in a war veteran in this movie. one of the things that happens is PTSD causes a decrease in serotonin. So by decreasing serotonin in the brain, what we get is increased impulsivity and aggression, and increased irritability. So these individuals are in a constant state of irritability, and they start engaging in obsessive, repetitive, and rigid behaviors, which makes it very difficult to treat these individuals with psychotherapy and to try to break those repetitive behaviors. So the serotonin reuptake inhibitors have been found to be very useful in the treatment of PTSD because they replenish the reserves of serotonin in the brain. Here we have Mel Gibson, who plays a detective with severe PTSD, and we're going to see some of the characteristics that that he portrays in the next slide. So the endogenous opioids also play a part in PTSD. So when we go through emotional or physical pain, we get our own internal anesthesia. So in this state of hyperarousal, there's a secretion of endogenous opioids, and it can be triggered by exposure to the event itself or to traumatic reminders of PTSD. And so this is what explains the blunting of the pain response in many traumatic situations. It has been described in the literature that many soldiers became addicted to combat situations. They wanted to go back to horrific combat situations. And it is hypothesized that some of it had to do with looking for that endogenous opioid discharge. And this is something that can also cause a compulsion to repeat and to court dangerous situations. And it's also apparently related to people who develop sadomasochistic sexual perversions after being sexually traumatized. Glucocorticoids also play a role in PTSD. We have the whole algorithm of the human stress response with increased allostatic load, that is the inability to return to the previous state of tranquility. And this leads to neuroendocrine dysregulation, and by upsetting the equilibrium in the hypothalamic pituitary axis, one ends up with obesity, high blood pressure, hyperthyroidism, cardiovascular disease, premature aging, and disorders of mood and behavior. And anybody that has rotated through a veterans hospital here in the United States can witness this just by walking through the hallways of the Veterans Hospital. Here is the hypothalamic pituitary axis, and when it's dysregulated, one of the things that results is a release of pro-inflammatory cytokines, and the pro-inflammatory cytokines bind to skeletal muscle, causing chronic muscular pain. And this is what accounts for these chronic pain syndromes that are usually related to early adverse life events, that people who have had a lot of trauma in childhood oftentimes end up suffering from chronic fatigue, polymyositis, and other intractable pain syndromes. Talking about premature aging and stress, here I like to show this slide. President Carter, when he became president and halfway through his presidency, and he was only president for 4 years, and this is Bill Clinton before and after. So you see that where a president of the United States ages 15 years in a 4-year or 8-year period. We're going to talk a little bit about trauma and memory now. So the amygdala, as we all know, is what assigns a feeling to an incoming stimulus. So the emotional meaning of the stimulus is assigned by the amygdala, and the hippocampus is what connects with the amygdala and describes or tells the story about the emotion. So one of the things that happens with PTSD, that it's kind of like a power surge. The intensity disconnects the amygdala from the hippocampus, and many people who've been traumatized have amnesias and are unable to tell the story of the event because of this disconnection between the amygdala and the hippocampus. And so the trauma then is recorded as a visceral memory or as a body memory. And Bessel van der Kolk speaks about this in his books amply, about in his book titled The Body Keeps the Score. So the traumatized person has body memories, but cannot tell the story of the event. Okay, so now we go to treatment. First of all, adaptation does not mean immediate full recovery. Many people who have gone through post-traumatic stress disorder or are suffering from post-traumatic stress disorder have suffered losses, including the loss of the illusion of safety, many times the loss of a country, a culture, a way of life, family members, a nationality, etc. So they have to go through the stages of grief. And the stages of grief are necessary because it's what allows us to slowly get up and go on living. And the stages of grief, as described by Kubler-Ross, they don't necessarily follow a linear order, and many times they take years to complete, and the grief may always be present, but it's tolerable and it allows us to go on living. One of the things that is important is the construction of a narrative, because as we mentioned earlier, one of the things that's lost in post-traumatic stress disorder is the ability to narrate the event. So the pandemic experience, which has included death and non-death losses, also includes the loss of hopes and dreams. So in the particular case of the pandemic, the psychotherapy and the narrative that the patient needs to construct includes how and why did this happen? Could it have been prevented? How to make it more bearable? How to build a new life? How to prevent future tragedies? How to integrate this experience to my entire life experience? And our role as therapists and psychiatrists is not to inject or force or provide a meaning to those who are struggling, but to facilitate their meaning-making process. So it's the patient who has to arrive at their own personal meaning. Okay, so talking a little bit about enforced confinement. So enforced confinement is part of what has happened with the pandemic. We have all had to forcefully isolate. And if we look at imprisonment, this is the solitary cell here. Enforced confinement can be a form of cruel and unusual punishment when it's imposed on people. However, sometimes when people isolate, it allows people to introspect, and it can actually have positive effects. For example, many prisoners have found a rebirth in their imprisonment because it allows them to reflect and reconstruct their internal structures. However, parents, for example, discipline their young children by sending them to their room, and in prisons, solitary confinement many times have been outlawed because it can lead to psychosis with the lack of stimulation. But if we look at Winnicott, the British pediatrician psychoanalyst, Winnicott talked about the capacity to be alone, and the capacity to be alone is roughly equivalent to Bowlby's concept of secure attachment. So if you have good internalized objects, this is a sign of emotional maturity, and the person can tolerate solitude and actually enjoy solitude in many situations. So the solitude that comes out of the pandemic could be an opportunity for the promotion of self-reflection, intrapsychic growth, increased creativity, the achievement of an internal harmonious state, and even a spiritual or religious self-discovery. And if we look at the psychoanalytic origins of our profession, when the patient is in an analytic room, the patient is usually alone in the presence of the analyst, and the analyst takes a back role, literally, to the patient's intrapsychic process and allows the patient to elaborate in the patient's own internal world. So the use of the couch was purposely designed by Freud to avoid eye contact with the analyst so that the patient would not be distracted by the body language of the analyst, that could concentrate more on the patient's own internal world. So many psychiatrists and therapists have discovered that doing telephone psychotherapy sessions without the aid of visual aid actually facilitates self-reflection and a turning of the patient into their own internal world. And of course, the creative process many times comes from situations of solitude. The concept of time as an intrapsychic organizer should be mentioned here, because our concept of time is linear. One moment follows another one like beads in a string, is what Kurt Vonnegut said in one of his novels. But in reality, in our internal intrapsychic experience, time moves back and forth, kind of like in a time tunnel or time traveling. So transference, for example, has to do with experiencing something in the present, but the person checks with the experience that they felt in the past and compare the two. And so the intrapsychic life, time is not a time of succession in a linear concept, but one of interaction, where we move back and forth between the past and the present. And so one of the things that happens is that we have distortions of the perception of time. And these distortions of the perception of time are very common now during the COVID pandemic. And the perceptions of time can be altered by things like anxiety, loss, shame, and other unpleasant affects, which occasionally want us to run away, and so to get out of there quickly, or escape a temporal reality. And other times the person feels that time is prolonged and that they are trapped and unable to experience escape from a painful temporal reality, and the time becomes unbearably prolonged. So these distortions of the perception of time are oftentimes defenses against all these unpleasant affects. And especially mourning is a very unpleasant and painful affect, and it can be perceived as unbearably prolonged during the COVID. The role of memory is also important to keep in mind. These are the first drawings that we know of human beings, and in the caves of Altamira, and these are the hands of the Australian Aborigines from thousands of years ago. And it's a way that human beings want to remember, the scenes of the hunt, what happened the day before. You turn it into a visual narrative. And what part of the recovery of the trauma is, since there's no story many times to the trauma, is the creation of a narrative. The narrative memory first develops when children are between 3 and 6 years old, alongside the development of language. And so when we work in psychotherapy with traumatized patients, we create a narrative truth, not a historical truth, because the historical truth would be the exact representation of the event, which is impossible to recover. But the narrative truth is an attempt at interpreting and understanding the memory of the event with the conviction that the interpretation given by the narrator must be true. So the most important thing is that the narrative of the past event makes sense to the patient and the therapist. And if we look at trauma, one could conceptualize trauma as a broken life narrative or life stories gone awry. And then psychotherapy can be conceptualized as a repairing of the life story. So a healthy individual is one who has a coherent, dynamic, and meaningful narrative of the self. The goals of psychotherapy. In psychotherapy, the therapist and the patient work jointly at creating an alternative story which is richer and in which identity is promoted, so the person grows from the experience of the trauma. And this allows the individual to have a narrative of how we got to be the way we are, how to shape our future, how to give our lives heightened meaning and understanding. So growth can actually come from trauma. Another gain that can be taken from trauma is transcendence and spirituality. Transcendence and spirituality may lead to a redefinition of the priorities and values of the life meaning of the person, emotional connections, redefinition and reaffirmation of the individual's identity, and the life purpose. What is really important in our lives? And many people who have been isolated by the pandemic have actually been enriched spiritually from the isolation. So cognitive behavioral therapy continues to be the most effective treatment for PTSD out of all the talking therapies. Play therapy in children is not systematized, and it facilitates expression, but there's not a lot of empirical evidence. Psychodynamic therapy, we know it works, but is very difficult to get empirical data. But from anecdotal data, there's a lot of things that can be gained from psychodynamic therapy. And psychological debriefing, which was used many times with disasters and the military, has been found in some studies to actually be detrimental, because it allows the person to relive the trauma, but there's no working through of the trauma. Now, pharmacologically, we have clonidine, which is helpful for the symptoms of hyperarousal and sleep disturbance, propranolol for aggression, irritability, and hyperarousal. The SSRIs we mentioned earlier, because of the effect over serotonin, which is decreased as a result of PTSD, can be helpful for irritability, depression, withdrawal, and repetitive behaviors. Buspirone is good for anxiety and hyperarousal, and other off-label medications include lithium, guanfacine, diphenhydramine, and hydroxyzine. It's very important to remember that we should avoid benzodiazepines and zolpidem and other sleep aids that can be potentially addictive. Finally, the most important thing about trauma is looking at the possibility of moving on. Tragedy many times engenders higher empathic attunement to other human beings, deeper emotional connections, more compassion, the ability to connect the past, the present, and the future, the evaluation of life in its entire dimension, and appreciating the value of living and valuing the moment. Okay, here are some references to PTSD, and thank you very much.